Hello and good day. We'd like to thank you all for attending this webinar. My name is Dr. Mo Abuzari, and I am the Senior Medical Science Liaison with MeMed Diagnostics. I have the pleasure of moderating today's webinar. Before we get started, I have a few quick housekeeping items. The webinar interface is completely customizable, and you can resize or move any of the modules to get the most out of your interface. We will be answering questions at the end of the presentation throughout the Ask the Question module. All questions will be anonymously directed to me and won't be visible to the group. We'll answer any logistical questions throughout the webinar, but we'll answer as many of your questions for the speaker at the end of the webcast. Anything we can't get to, we'll answer via email. Lastly, if you're attending with a group of people on the same line, please, throughout the Q&A, let us know how many people are in your group, and it will help us with attendance. With the housekeeping out of the way, I'm very pleased to introduce our speaker, Dr. Kevin Garey, PharmD, MS, FA, FHP. He is a professor at the University of Houston College of Pharmacy and chair of Department of Pharmacy Practice and Translational Research. He is an adjunct professor at University of Texas School of Public Health and a clinical specialist and a researcher at Baylor St. Luke's Medical Center, Houston, Texas. He received his Bachelor of Science in Pharmacy degree from Delahue University in Halifax, Nova Scotia, Canada, a Doctor of Pharmacy from sunny Buffalo in Buffalo, New York, and a Master of Science in Biometry from University of Texas School of Public Health. His postdoctoral training include a pharmacy practice residency at Bassett Healthcare, Cooperstown, New York, an infectious disease specialty residency and fellowship training at the University of Illinois at Chicago, Illinois. He is a member of IDSA Standard and Practice Guideline Committee and is a member of IDSA Society of Healthcare Epidemiology of America Practice Guideline for C. diff infection. He's an active member of Society of Infectious Disease Pharmacists and the American Society of Health System Pharmacists. His award includes ASHP Best Practice Award in Health System Pharmacy Administration 2010, ASHP Drug Therapy Research Award 2007, and a SIDP Impact Paper in Infectious Disease Pharmacotherapy Research Award 2007 and 2012. Additionally, he received the University of Houston PLS Leadership Award in 2013. His research is supported by National Institute of Health, the Center for Disease Control and Prevention, and the biotechnology industry. He has published over 220 manuscripts centered on clinical and translational research in healthcare-associated infection, include healthcare-related infection, candidemia, and Clostridium difficile infection. With that said, Dr. Garey, the floor is yours. Thank you.
Okay, thank you, Mo, for that kind introduction. Hi, everyone. So for those of you who maybe just randomly clicked on the webinar button and may not be familiar with the MeMed BV diagnostic, so it's FDA cleared, and what this diagnostic will do, it'll help us distinguish viral from bacterial infection. That's its secret sauce. And so many stewardship programs around the country now are going to then be asking the question of how do we use this new diagnostic? And since it's World Antimicrobial Awareness Week, I want to phrase this around antimicrobial resistant AMR. And so to build this case of how to use it, I want to break this talk into three parts. Part one, sort of justifying that AMR is bad. That'll be part one. And then that's kind of doom and gloom. But then part two is sort of a ray of sunshine but there's a lot of room to improve our antimicrobial prescribing. And then part three will be where this MeMed BV diagnostic could fit in and help us to prevent the overuse of inappropriate antimicrobials. So with that, let's get started. Okay, so early 1900s, 1930s, let's say, Alexander Fleming invents penicillin. Yay him. And if you look back in the early 1900s and you looked at the top 10 reasons for the population mortality, you'll see that infectious diseases was 1 through 10. And fast forward to 2021, and you'll recognize that most of those top 10 infectious diseases have gone away, replaced with chronic diseases, heart disease, cancer, diabetes. And the reason for that has been the power of antimicrobials. And so this is just a great illustration. This is pneumococcal pneumonia. This is community-acquired pneumonia. This is the most common pathogen. And before the antibiotic era, this was a death sentence for most, almost an 80% mortality rate. And it's just the transformation that antimicrobials has done to improve human health is really outstanding, and this is just one of many. And you sort of pick your favorite infectious diseases: community-acquired pneumonia, hospital pneumonia, heart infections, brain infections, skin infections, and the ability for antimicrobials to save lives is really, really amazing. And I love this slide because like aspirin, which we think is a great life-saving pharmacological for heart attacks, like it does save lives, but not even close to the extent that antimicrobials do. And now, it's funny enough, the year that Alexander Fleming invented penicillin and was published, it was the next year that they found penicillin-resistant staph. And so as soon as you invent an antibiotic, it doesn't take very long to get you to some organism, some bacteria, that then is resistant to that exact same antibiotic, unfortunately. And so it's really well recognized that antimicrobial resistance is not an individual problem, but it's a public health threat. And there are a lot of resources put into trying to prevent the spread of AMR and trying to prevent it from developing in the first place. So these are recent estimates of how much in the U.S. CDC estimates is antimicrobial resistance affecting us. 2.8 million infections, 35,000 plus deaths. If you add C. diff into that, another 250 to higher than that cases, 12,800 deaths. So obviously it's a big deal. So what the CDC does then is they kind of keep their eyes on resistance trends and what is sort of the next ones that are coming or the ones that we really have to pay attention to. And they divide these into urgent, serious, concerning, and then something they say watch, which is emerging. But these are all household names. Acinetobacter infection, C. diff infection, VRE, MRSA. It's not uncommon that everybody now knows these names. And it's also important to note that we are really trying to prevent the spread of not only these organisms, but number 5, the next one to come. Now, World Antimicrobial Awareness Week is actually a WHO event, a World Health Authority event. So WHO has similar as well, a laundry list of priority organisms with developing AMR. And you'll see it's important on the inpatient, Pseudomonas, for example, Enterobacteriaceae, and the outpatient. There's strep pneumo. The savior slide I showed you a few slides ago. There is enough resistance out there that the ability of our antibiotics to kill it is going away. Now, the other thing that's now, I think, much better appreciated by work from the World Bank and others is how much this antimicrobial resistance is impacting world population GDP, our economic growth, and our ability to better ourselves as a world is actually impacted by antimicrobial resistance. And so what the World Bank has done, they say, well, if we are progressing at this particular rate of antimicrobial resistance, and if it stays lower, low AMR, that dark line, or if it's higher, we have two different estimates, and that's that sort of that yellow dotty barry line. It could either have like a 1 to as much as a 4% decrease in global economic output because of AMR. And then a really neat way to illustrate that is the bar here in the red. That's the financial crisis of 2008, 2009. Banks collapsed, worldwide depression in the economy. And so that obviously hurt a lot of people. Minus Forbes sticks out for your high-income countries, for example, and a minus 3.6% GDP worldwide. So in that same low AMR scenario or high AMR scenario, you can see that at a reasonable estimate, that high AMR scenario, by 2050, it will have more of an impact than the global financial crisis of 2008, 2009, dimming the economic prospects of the world tremendously. And if you think about it, what AMR represents is a return to a time period when we no longer have antimicrobials. And as I sort of mentioned in that Alexander Fleming slide, if you look back in the 1900s, it was pneumonia, and TB that killed you. And that's the world we would return to if the AMR crisis is not solved. So the same estimates would be that by 2050, AMR will cause more death than cancer and diabetes combined. And this will affect developing worlds, probably disproportionately more than developed. Developing worlds need to use antimicrobials as part of their infection control prevention strategies because the other things aren't in place as well, the other infection control practices. So not only will it affect globally, but it'll affect those populations most at risk for poor outcomes, the developing world. So it won't even be fair. It will be essentially a worldwide decrease in GDP with lots and lots of deaths. Now, what we have generally done in the world of AMR is just keep inventing new antibiotics. Just stay one step ahead of the bacteria. And that, unfortunately, is just not going to work. That's what's showing on the left of this slide. We just do not have the pipeline to keep up with the development of resistance that's happening. And on the right, which is probably a talk all on its own, is the way we use antimicrobials is probably wrong, and the way we get new antimicrobials at the door. But I think we'll save that for another day. Simply knowing the fact that we're not going to invent our way out of this problem. Okay, so that's a little bit of doom and gloom, but it does help set the stage. And I think there's still a lot of, not maybe a lot, the argument that AMR is bad is really solid. It's bad from a patient perspective. It's bad all the way up to the human population perspective. Now, you'll still get some naysayers that say, whatever. I think you should still lead with that, not only for World Antimicrobial Awareness Week, but I think pick your bad bug in your hospital, BRE, multidrug-resistant Pseudomonas, strep pneumo, and lead with that. This bug is bad. We need to do something to prevent it from getting any worse, and ideally improve it. That's part one. AMR is bad. Part two. I think luckily for us, there is going to be room to improve the AMR crisis. And nice for MeMed BV, it's in the sweet spot of stop using so many, gosh darn, antibiotics. And so this is part two. So 47 million prescriptions in the U.S. per year are considered unnecessary. And so this is actually a conservative estimate that 3 out of every 10, 30% of the time, you probably didn't need that antibiotic to begin with. And I think underappreciated what would be, well, these drugs aren't that toxic. You don't get many side effects from them, whatever. So AMR is obviously the big one we're leading with today, but I just wanted to put one slide in. There's a lot of other things that happen when you give an antimicrobial, and your healthy microbiota, the microbiota that lives in your body, your gut, pulmonary space, elsewhere, they're synergistic. They're considered an organ. And overuse of antibiotics hurts that organ, obviously. And so if you have an infection, you have to treat it, and obviously put up with the collateral damage if you damage your microbiome. But if it's unnecessary, you may be causing more damage. So overuse of antibiotics is linked to obesity, diabetes, IBD, asthma, some autoimmune diseases, and all of that is through destruction of your healthy microbiome. I just wanted to put one slide in there on that. Excuse me. So if you look around the U.S., those numbers equate to almost one course of an antibiotic for every single American in the United States. And obviously, some states are worse than others. West Virginia is always called out as the highest state, 1.2 courses, 1.285 courses per every single person in that state. So there's an awful lot of consumption out there. And if anyone ever says, well, I don't really believe that antimicrobial use causes antimicrobial resistance, just call them out and say, that's just not correct. And there's plenty of data there similar to this showing there's almost perfect correlation between azithromycin, a macrolide, and then macrolide resistance going up pretty much lockstep and barrel. And then, so all the sort of those bad bugs that we see on the CDC list or the WHO list, they're all associated with overuse of a certain type of antibiotic. Third-generation cephalosporins, increased resistance to everything, lots of lines, MRSA, VRE, C. diff, likewise fluoroquinolones and carbapenems. And remember that even before this, no one ever really gets started on a carbapenem. They will have a first-generation cephalosporin. They'll have a ampicillin. There's a whole long laundry list of antibiotics that patients generally will be on before they get these bad bugs of the day. And anything we can do to break that cycle of overuse of antimicrobials, no matter where it is in the pipeline, will prevent these bugs from becoming more resistant. Now, I want to just, if you look and see, well, how are these things unnecessary? This paper by Hecker is probably one of the more classic ones. But if you just look at that second one, non-infectious, non-antibacterial syndrome, a third of all patients were treated with an antibiotic and then eventually found out to not have any sort of bacterial infection. So recent estimates from the CDC Get Smart program, that's that top line. Antimicrobial not indicated. And that's a quarter in the CDC Get Smart one, a quarter of the time. And then that incorrect duration, incorrect dose also fits into this. Well, maybe they shouldn't even had it in the first place. So CDC estimates, that's where that 30% came from. And it could be as high as 50% of inpatient use is inappropriate. Okay, it wasn't a bacterial origin to begin with, or suboptimal. So where are you seeing a lot of this? And it's exactly what you think it is. It's urgent care centers, it's emergency departments, it's very busy areas where you have to make quick decisions, and so you'll generally err on the side of, I'm not sure if this is bacterial or not, so I'll give an antibiotic. And so you can see where we may think about using a diagnostic that can distinguish between viral and bacterial. It's going to be in the exact same places. So part 2 is really just a summary of parts 1 and 2 combined. So really, antibiotics are really misused, and they're really misused everywhere. But that might be good. because we know AMR is bad. But and we know that antibiotic use causes AMR, but if 100% of that antibiotic use was appropriate, well, we're hosed because we have to use the antibiotic. But if up to half are inappropriate, then we just need to have a better way to figure out who has a viral infection versus who has a bacterial infection, and don't treat viral infections with an antibiotic. So there's actually a little bit of glimmer and a sort of a ray of hope, given all this depressing part 1 and 2 of this talk. So if you kind of look at those slides and put them all together, there's going to be a lot of different places where we can optimize the use of a test to help us decide whether to use an antibiotic or not. So that's great. So end of part 1, there's a lot of work to be done to slow down the AMR crisis. But luckily for us, there's lots of places for intervention. Okay, well, like I think if I talk to Quinn, my 11-year-old, and I told him, you know, virus aren't treated with an antibiotic, and then he might tell me, okay, then I don't want an antibiotic if I have a virus. And yeah, he'd be totally right. But the problem is this. Clinically, most patients with infectious diseases, it's hard to distinguish. There are certain things that are more likely in one bacterial infection versus another viral infection. But there's a lot of overlap. And so you'll have cases that are straightforward this or straightforward that. But for the most part, it's a little mixed in the middle, so you're never 100% sure. And that makes a lot of sense to me. And then that makes a lot of sense why it's so hard to prevent the overuse of antimicrobials, because that inappropriate is always defined days or weeks later once you have all the data back. But at that point of care, when you see this guy with this stuffy nose with fever, myalgias, and it was okay a couple of days ago, and his chest hurts and he coughs, other stuff, does he have bacteria or does he have viral? And the answer is lots of times, I'm not 100% sure. So the one nice thing about us being humans is our bodies are remarkably adept at helping us cope with infectious diseases. And our body's response is really tailored to, is there a bacteria in my body right now? Or is there a virus in my body right now? And so that host immune response can actually really help us to determine, it helps us to determine what's in there, and we can use that to our advantage in terms of a diagnostic. And so in this cartoon of mine, bring in the bacterial host response if you have bacteria, bring in the viral if you have a virus. And so we do this clinically. So this is really the procalcitonin that many of us are familiar with. IL-6 used in Europe, probably more than in the US. C-reactive protein. These are all biomarkers that is our own body's response to either a viral or a bacterial infection in this particular case. So this is then the start of MeMed BV and the BV signature, and they've done a good job of naming their studies. And the first one out was the Curiosity study, and this is what identified their signature traits that they have, their host proteins, the human response to infection. So if you start over on the left-hand side, and so you see those 20 patients, so they did a gigantic proteomic screen on these 20 patients to see what is really up when you have a bacterial infection, what is really up or down when you have a viral infection. And then from those 600, you pick your best 86, and you use a much bigger population. This is 100. And you run that same thing again. And then from that, you run a smaller subset, but on a bigger population. So you can see you sort of train and learn and train and learn and train and learn. And once you get down to, let's say, that 17, you can ask yourself the question, once I know one, what's the advantage of putting in a second one? And is it important or not? Once I put in a second one, what's the advantage of putting in a third one? And then et cetera, et cetera. And so what they did, this is where that logistic regression came from, and they came out with 3 host proteins, TRAIL, IP10, and C-reactive protein, CRP. And once you accounted for these 3, adding a 4th one was no benefit. So 3 host proteins to help you distinguish between a bacterial versus a viral infection. This is really cool stuff. So what is TRAIL and IP10 and CRP, you ask? Well, that is a fabulous question. So TRAIL, tumor necrosis factor-related apoptosis-inducing ligand. Whew. So it's up a lot with viral infections. And so this is the neat part of this BV signature. So you can see the A chart, and viral is the middle one, and you can see there's a lot more up of TRAIL when you have a viral infection. But you can see there's a few bacterial that are up, and the non-infectious is a little bit up every now and then. So any one isn't perfect, and that's where this 3 comes in. IP10, interferon gamma-induced protein. So let's do the same exercise again. The viral looks like it's quite a bit up compared to the non-infectious on the right. And the left on the bacterial, it looks like it's up too, but maybe not to the same extent as viral. Okay, got it. So CRP, C-reactive protein, looks to be more up in the bacterial one. So it's going to be some sort of signature that you get from these 3 host proteins that will help you predict whether somebody has a bacterial or a viral infection or not. And putting this together into sort of a figure cartoon, so you can see, so IP10, you can see that right in the middle underneath the person's lungs. So you can see that goes down a viral or a bacterial infection route. You get IP10 upregulated, but viral more than bacterial. And if you go down to that red B versus blue V, that's just illustrating that in viral infections, they'll be up more so than in bacterial infections. And then vice versa for CRP, which more goes down a bacterial pathway. So you'll get a higher level there with bacterial versus viral. And TRAIL really is viral specific. And so you'll get lower numbers in bacterial versus viral. So that's the pathophys of what's happening here. So then that top figure on the right, that's just simply illustrating my cartoon that I began with, that clinical symptoms are really, really hard to predict. So like maximal temperature, for example, and up is good in this particular chart. 0.5, which is flipping a coin. Not very good at all at distinguishing bacterial versus viral. Respiratory rate, not much better. And then go all the way across to optimal pair. So if retrospectively you could look in your crystal ball and say, which of these 2 are the best predictors, that gets you up to like 75%. If you pick 3, not much better, and you pick even 4 of those clinical symptoms. So it's really hard to distinguish bacterial versus viral using clinical symptoms. That's what that's trying to illustrate to you. And that word signature, that's the MeMed BV test, which is giving you an AUC of over 90%, which is good. And then if you go to that bottom figure, just procalcitonin, TREM, CD80, bunch of interleukins, TNF-alpha. These are other host proteins that are produced. And you can see that no one individual host protein is really anywhere near what you get out of the 3, the CRP, IP10, and TRAIL that's in the MeMed BV. So that's what that's trying to illustrate to you. So that's super cool. Like, obviously, procalcitonin is something we're familiar with. This looks like it's a step forward of that, and it looks like it's good at predicting with sensitivity and specificity. That's where that high AUC of 90% comes from. So we can now go into the clinical trials that said, well, where can we use this thing? And so this was the Opportunity study. This was a big one they produced in Lancet ID. And all of these studies go down a similar pathway, and it's kind of a cool way to do it. So a lot of these new diagnostics suffer from how do you identify a gold standard? Like, this whole invention is based around the fact that it's super hard to distinguish between viral versus bacterial infection. So what you can do is you can take some experts. This is children, so you grab some pediatricians, and you blind them to the MeMed BV results, but you give them absolutely everything they could ever want to try to distinguish between a bacterial versus viral infection. And if you go down this consort diagram, you will see 71 diagnosed as bacterial by expert panel. So that's the gold standard. And 435 diagnosed as viral, 71 diagnosed as inconclusive. So you can then match up that gold standard to whatever the MeMed BV test said and see how it compares to each other. Now, interestingly enough, remember that although that's defined as the gold standard and it's pretty good, probably the best you're ever going to get, they could be wrong. Interesting enough, like they just truly don't have enough data to make that call. So it's the best opinion. Okay, so but with that, in these large number of children with lower respiratory tract infection or fever of unknown origin, and this is going to be where we're going to use it hint, the low-hanging fruit. It performed really well. The red there is the index test with an AUC again of 90% in this case. The green is a C-reactive protein all by itself. So IP10 and trail improved upon CRP as it should. And then the blue line there is procalcitonin, which didn't work even as well as CRP by itself. So this is one of their big papers, and so one of the really cool places that's going to be used is kids with lower respiratory tract infections or fever of unknown origin. And really, really nice, because that's a place that CDC has really said that there's a massive overprescribing of antimicrobials in this exact same population. And back to my microbiome slide, this shows that can have some negative long-term consequences by giving kids antimicrobials. This could reduce antimicrobials in kids by half, if not more. That was a cool study. Another kid study, this one was called the Pathfinder, doing the same thing again, grabbing kids old, up to 18 years in this particular case, and then with fever and symptom duration less than 7 days. Once again, using that sort of that expert opinion as the gold standard. And I wanted to just, I like this because it's kind of cool. You see the trail up with viral, not up with bacterial, the IP10 up a little bit more in viral, but both are kind of up. CRP more up in bacterial and viral. So it illustrates it's doing what it's supposed to be doing. And then that assay score, you can see that you get this score of 0 to 35, and they're just kind of, that's where that blue box ends. And so there's obviously like a little bit of viral above that, but that you see a huge amount of the viral cases in that 0 to 35 range. And then that blue box of, in this case, it's 80 to 100, but even that, you can see a little black line, 65 to 100. You can see the vast majority of the bacterial cases had that score. And so then you get this equivocal, which then this assay isn't exactly sure, so use your best guess, which is kind of cool. It's kind of like, okay, we're not sure, we're not going to say we are. Either repeat the test, maybe, or you have to go back to your own expert clinical opinion again. So put that all together, sensitivity is 93.8%, specificity is round up to 90%, 89.8%. Really good sensitivity specificity. Okay, so the original study, the one where they did all that proteinomics, they've done a number of nice little sub-studies off that as well, and looking at possible comparators. And so there's CRP, IL-6, procalcitonin, and then the MeMed BV as well. And the only reason the reason I'm illustrating this is that one stat. 50 of 57 patients from this sub-analysis, 88% identified as viral bacterial origin received an antibiotic. And that just illustrates how much this could change the way we use antimicrobials and prevention of AMR. So this I would like to see some more real-world data once this starts getting used of how much we can save in antibiotics and then how much that helped prevent AMR. But this just kind of lights up as, whew, that could go down to 0? And the answer is maybe, or at least a lot less than that. Okay, and then this is hot off the press. This is the Apollo study, which is the first foray into the U.S. So big one. USA, Israel, and Europe. 584 adults, 432 children, ED and urgent care settings. Remember, that's where the inappropriate antibiotics are used. Way to go to study it in that exact correct place. And then same as always, suspected infection. They had to have a fever, symptom duration less than 7 days, and they used their same gold standard method again. Once again, getting really good sensitivity, specificity. Now, if you don't react to that indeterminate, you just say, okay, if it's true bacteria, was a bacteria. If it says true virus, was a virus. Their sensitivity, specificity, and negative prediction value was spectacularly good. So if you don't react to that indeterminate, which you're not supposed to, and it says viral, your negative predictive value is 99.3%. You will not need to use an antibiotic. That's really cool. And so what the two figures are showing is simply compared to procalcitonin, it outperformed procalcitonin. With an AUC of 0.9 if you include those indeterminants, and 0.97 if you remove the indeterminants. So that's the data, and the Apollo study is still to be published. That was from a abstract, but that should hopefully be coming out soon. So that's what you'll be going with your antimicrobial stewardship programs. And I just want to close this lecture off with some thoughts around ASP and the arguments you can make of why to incorporate it into your stewardship programs. And most of the things we use every day to justify stewardship programs really fit well with a diagnostic. It can stop you from using an antibiotic. So, and then I just want to walk through a couple. So many people are familiar with antimicrobial stewardship programs, but there's obviously a big laundry list of people that are interested in optimal use of antimicrobials, not only to prevent resistance, but preventing poor patient outcomes, costs, obviously lots. But the two things are going to usually, the two main champions are generally going to be your clinical ID pharmacist or just your ID pharmacist, and then a physician champion, usually an ID physician. Those two persons are generally going to really direct the stewardship program in all its facets. So one of the things that really you put the Bible of antimicrobial stewardship programs is the National Action Plan for Combating Antibiotic-Resistant Bacteria, CARB, which was published in 2015 and is still used a lot by the CDC and others to build our benchmarks of what we need to accomplish. I just want to illustrate this. Reduce inappropriate antibiotic use by 50% in outpatient settings and 20% in inpatient settings. And that has been really, really hard to do because of all of the variety of reasons why it's hard to figure out who has a viral or who has a bacterial infection. Remember the slide I showed you, that last slide of the MeMed BV, where 88% of patients with a viral infection got an antibiotic? Well, if I could even get that down to like 2/3 not getting the antimicrobial, I'm going to hit the targets outlined in the PCAST. Thank you, President Obama, for setting that up. And there might be a way now to actually hit those targets. But I'm going a little crazy with my thumbs up. But if we could do that, I'm a C. diff guy, so we could reduce lots of secondary problems associated with antimicrobials. This is an AMR talk, which is why I said this could really limit the emergence of that. And I really like the thoughts of if you could break the chain early, don't give that ampicillin sulbactam in kids. That could really have a profound change for a lot of the other stuff we do too, because maybe they don't show up with AMR in our ICUs. So there's lots and lots of places where knowing where an antibacterial is needed and when a person has a viral infection, so therefore an antibiotic is not needed, is needed. So there you go. It all kind of boils down to a pretty simple case. It takes us 40 minutes to get here, but the best way to reduce use of antibiotics and therefore reduce AMR is never to start one in the first place. And so this BV test, I'm excited about it. This is really the first one that I think you can reliably say no need for it. Pediatricians who, like moms and dads who really want their little kid to get an antibiotic, they now have something they could use to say, you know, we did this test, viral, problems with antimicrobials, we don't want to give it to you. And that would give everybody the data they need to make some rational decisions. So back, just finishing up with my happy faces. So there's a lot of places where a BV signature test could be a really nice tool for ASAP programs. So if I was kind of making an argument, I would say, well, what's my problem bug? It's strep pneumo, obviously, in the respiratory tract field. Anopheles is a lot. Like, what's my problem bug? And start there. Use the CDC or the WHO threat level organisms to kind of get you started. And then if you're really trying to prove the value of this, so what antibiotics are we using that are causing this problem? And then if we were to use BV signature, could we not only prevent the overuse of that antimicrobial, but prevent the AMR to go along with it? So that's why I think this is actually, it's kind of gloom and doom parts 1 and 2. But I still like the fact that AMR is rising in a world where we use too many unnecessary antibiotics. And I think this is a really nice diagnostic that can take care of the don't use it when it's not needed problem. So Mo, I will turn it to you for the Q&A session. And thanks again for the opportunity to present today.
Thank you very, very much. Wow, what a great presentation. And some questions did came up during the presentation, so I will ask them as they have come in. Where in the ED workflow do you see a BV signature can have the most impact in the patient care?
In the ED, and if you're following the data, you're going to use it first and foremost for respiratory tract infections. And obviously, in the world of COVID, and even in any world, there's an awful lot of respiratory tract infections out there. And then there's also the fact in every place, I'm going to say even a busy ED, that's exactly where you have an awful lot of overuse of antibiotics and where you get an awful lot of AMR. So I think first and foremost, as you're starting down this road with the MeMed BV, you're going to target for respiratory tract infections, trying to distinguish between viral and bacterial, and use your stewardship teams to say react to those tests appropriately, and then start it, don't stop. Start it, don't start antibiotics.
Great. You kind of hinted on this, but for specifically, and you mentioned it at the moment, but what clinical indications, like where do you see if somebody comes in and you're suspecting an infection, what sign and symptoms is BV going to have the most benefit for a clinician?
Well, you know, I've liked the fact that MeMed has really done a good job of developing their clinical trials to mimic probably what clinicians are going to be looking at. And every study has started with fever, and then a specific duration of symptoms, less than 7 days usually. And I think that's what we're going to use. Ironically, we can use that data from those studies to build this up clinically. Is someone walking in the door with signs and symptoms of respiratory tract infection with a fever that hasn't been around for more than 7 days? I think that is a wonderful use of MeMed BV, because that's exactly where the inappropriate use of antibiotics, because it's so freaking hard to figure out bacterial versus viral in that exact patient population.
Great, thank you. Do you see the value for BV signature to be part of the automatic order set or an optional test where clinicians get to pick? I
think either. So I've thought a little bit about that question too. So whenever you get a sputum culture, should you then also get a MeMed BV test? That would be very intriguing to me, because the sputum culture takes 24 hours or more to come back, hence the problem why we can't decide. But every time you do that, if you also got a MeMed BV test, 15 minutes later you have the MeMed BV. If it's lighting up unequivocally or very high likelihood of viral, oh, that's a piece of data you can really use to help decide whether or not to use an antimicrobial or not. So I certainly see places where you could automate it, have a reflex to MeMed BV if this thing happens. Now, I also certainly see it as a place where it's a diagnostic test you could order as you order anything else, chest x-rays or blood cultures or anything. That's certainly a valid and good possibility as well.
Got it. Great. Thank you for that. How do you see the test identifying challenging bacterial infection that currently present as readmission with more severe symptoms?
Well, you know, I sort of hinted at it, and I just want to reemphasize it as well. So, no one shows up with an AMR organism. Like they have been treated before with an antimicrobial. And then, for whatever reason, that fails, or they got C. diff, or whatever, and now they're back in again with a difficult-to-treat infection, an AMR organism, or something. So there's a much longer chain of events than I think what is appreciated to get to that difficult-to-treat infection. And I am A-OK of stopping that anywhere in that chain to prevent the emergence of that resistance, making it more difficult to treat. So if that adult with suspected community-acquired pneumonia actually just had a viral illness, and therefore I didn't give ceftriaxone, but I did give Tamiflu, if it was the flu, yay us. And that might not only help that person to get better from, in this instance, their viral infection, but because you prevented the antibiotic, because you prevented the disruption to the microbiome, because you prevented maybe development of resistance, you could also really nicely affect a lot of downstream processes too.
Great, great. You know, this question comes up often, and I'm actually glad to see it somebody ask. Our current focus as clinicians is inpatient stewardship. And, you know, all these antimicrobial stewardship, which I'm sure you're very familiar with, their focus is what is it in for our hospital and inpatient regimen of stewardship treatment and so on and so forth. But the focus of MeMed BV test at the moment is outpatient stewardship or at the time of admission. So how do you see stewardship look into this idea, considering now in the next 3 years, that's going to be the next phase of stewardship? How do you see them immediately trying to look into this idea of outpatient stewardship?
Well, I would make an argument that outpatient stewardship might be where the action is at the moment. Dental stewardship, ambulatory care, nursing homes, long-term care facilities. These areas are booming in terms of opportunities for better optimizing your antimicrobials. Diagnostic stewardship is big in that area. So I would first and foremost say this is in the sweet spot for a lot of stewardship programs. One. Number two, it is a continuum of care. So you don't just you don't get beamed into the ICU by Star Trek and the boys. You have to go from the clinic to the ED to someplace, surgery maybe, and then you eventually land in the ICU. So anything you can do along that continuum, again, to when they do get there without so much AMR associated with yourself, aka don't use any antimicrobials that aren't needed along the way. I think MeMed BV has that potential. By every step along the way, is this antimicrobial really needed? Now, number 3, and finally, this is probably futuristic thinking, but it's not like every single antibacterial prescription in the hospital is right on target. Like, there's certainly lots and lots of overuse, but there is, since you're in a different acuity of care, aka patients are sicker, you have to make those decisions quick, and you really don't want to be wrong. They had a bacteria and you didn't give something is a bigger deal if you're in the ICU, obviously. But I think future studies by MeMed BV could go after that sicker patient population and maybe have an indeterminate section that makes sure you're not wrong, sort of thing. I do see a future where we're using this type of diagnostic in the inpatient setting as well, but that's obviously future.
Understood. Understood. I got 2 more questions, and I think that would conclude. You brought up COVID, and you know everybody was hoping that 2022 will be the year we won't have to worry about COVID, but as all the data that we see with all the ups and downs, it might not really truly be in our rear-view mirror. How would you see a MeMed BV test be utilized with COVID patients?
Well, I think it's certainly in the sweet spot. As I think everyone's aware, it's a respiratory tract infection of viral origin. And so in this case now, the excitement of new antivirals coming out that might have efficacy against COVID, well, that's a game changer in terms of appropriately treating patients. If I could have a 15-minute test that lights up and says viral, send a very quick PCR for COVID test and get someone on their appropriate antiviral, that's great. And then, like in a world where flu comes back, like there's certainly antivirals that are time dependent. We have to get them started in a timely fashion or they don't work. And a test like this that can get results back in under 30 minutes, let's say, that's really good for getting people started on the right treatment. And many times we forget that, well, there are actually right treatments for viral infections as well. We sometimes too much focus on the overuse of antibiotics, but in all honesty, it can also help us get on the appropriate antivirals.
Great, thank you. One last question is, with your experience in rapid diagnostic and clinical support, what step would you utilize to implement MeMed BV signature in your hospital workflow? Very good, and there is a correct answer to that question. And it's been proven many, many times. And that is when you set it up, make sure you assign someone to react to the results. That any sort of rapid diagnostic stewardship intervention does not work as well when you leave it up to the entire population to do the right thing all the time. So you set someone up to receive the alerts, and this probably is in the ED stewardship person, that understands what those results means and then knows how to react to those results. That's how you can almost guarantee yourself a home run with these types of new diagnostics coming out. Great, thank you. Well, with that, I'd like to thank you, Dr. Garey, for your time and everyone else for their time today to attend our webinar. If we didn't get a chance to answer your questions, please be sure to check your emails. We will make sure all questions are answered by the appropriate parties on the webinar. And I'd like to wish everyone a great day and a fantastic weekend coming up. Thank you very much.